Cytoreductive surgery with HIPEC standing for heated intraperitoneal chemotherapy, has transformed peritoneal mesothelioma from a uniformly fatal disease to one where long-term survival is possible. But this complex, grueling surgery isn't appropriate for everyone. Today, I want to explain exactly what makes someone a good candidate for cytoreductive surgery, what factors disqualify patients, how surgeons assess your eligibility, and what you should understand about the selection process before pursuing this option. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician and this isn't medical advice, but understanding who qualifies for cytoreductive surgery helps you evaluate whether this approach is realistic for your situation. Let's start with what cytoreductive surgery actually aims to accomplish. The goal is complete cytoreduction, which means removing all visible tumor from the peritoneal cavity or at least reducing it to tiny residual nodules less than 2.5 millimeters. This is designated as CC0, standing for complete cytoreduction with no visible residual disease, or CC1, standing for residual nodules less than 2.5 millimeters. Achieving CC0 or CC1 is absolutely critical because these patients have dramatically better outcomes than those left with larger residual disease. Studies consistently show that patients achieving complete cytoreduction have 5-year survival rates of 50 to 75% when it's performed at experienced centers. Patients with incomplete cytoreductions of CC2, representing residual disease of 2.5 millimeters to 2.5 centimeters, or CC3, representing residual disease over 2.5 centimeters, have much worse outcomes, often no better than chemotherapy alone. This is why patient selection is so rigorous. Surgeons only want to operate on patients for whom complete cytoreduction appears achievable. Subjecting patients to 8 to 12 hours of surgery, weeks of hospitalization, months of recovery, and significant complication risk is only justified if complete cytoreduction is likely. The first major qualification factor is disease extent and distribution. The Peritoneal Cancer Index, or PCI, quantifies tumor burden. The abdomen is divided into 13 regions, and tumor size in each region is scored from 0 to 3, creating a total score between 0 and 39. Most experienced surgeons consider a PCI under 20 to be favorable for surgery. Patients with PCI under 20 are excellent candidates because complete cytoreduction is usually achievable, and historically, these patients have the best outcomes. A PCI of 20 to 30 is considered an intermediate score. Surgery might still be worthwhile if the surgeon believes complete cytoreduction is achievable despite the higher tumor burden, but outcomes are more variable and the risk is higher. Now, before I go on, I'm going to take a break here and ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comment section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. If you have a PCI over 30 and up to 35, it's generally considered too extensive. Complete cytoreduction is unlikely with such widespread disease, so most surgeons won't operate. Some very aggressive surgeons might operate on patients with PCIs up to 39, but it's controversial and outcomes are generally poor. Beyond the overall PCI score, specific distribution of disease matters. Disease involving certain critical areas can make surgery impossible, even with a modest PCI. These include extensive involvement of areas where blood vessels enter the liver, which makes it impossible to clear the disease without causing catastrophic bleeding. massive involvement of the root of the mesentery where blood vessels supply the intestines. That prevents adequate resection. Diffuse small bowel involvement requiring removal of most of the small intestine, which would cause short bowel syndrome, and extensive disease in areas surgeons can't access safely. Cell type is the second critical qualification factor. Patients whose peritoneal mesothelioma is the epithelioid type are ideal candidates because the epithelioid cell type responds best to treatment and has the best overall prognosis. The excellent long-term survival data from cytoreductive surgery, that's from 50 to 75% 5-year survival, applies almost exclusively to epithelioid patients. Patients whose biphasic cell type of mesothelioma is predominantly epithelioid might still be surgical candidates, but outcomes are worse for them than for those with pure epithelioid disease. If the biphasic tumor is predominantly sarcomatoid, surgery is rarely beneficial, and patients whose peritoneal mesothelioma is sarcomatoid are generally not surgical candidates. This aggressive cell type grows rapidly, responds poorly to treatment, and recurs quickly, even after complete cytoreduction. So most surgeons won't perform cytoreductive surgery for sarcomatoid disease because the risks and burdens aren't justified by the accompanying poor expected outcomes. Age and overall health are the third major factor. There's no absolute age cutoff, but cytoreductive surgery with HIPEC is a massive physiologic stress. Older patients, particularly those over 75 to 80, have higher surgical risks and slower recovery. Performance status, that matters enormously. The Eastern Cooperative Oncology Group, or ECOG scale, rates functional status from 0, which is fully active, to 4, which is completely disabled. Patients with an ECOG score of 0 or 1, which means they're fully active or having symptoms but remain ambulatory and able to carry out light work, they're ideal surgical candidates. ECOG scores of 2 represent patients who are ambulatory but unable to work and up and about more than 50% of waking hours. They might be considered a surgical candidate in selected cases, but the risk is definitely higher. ECOG 3 or 4 patients are not surgical candidates. Comorbidities, which is other medical conditions, that affects candidacy too. Severe heart disease, kidney failure, liver cirrhosis, or other serious conditions increase surgical risk and could disqualify patients even if their peritoneal disease is resectable. Nutritional status matters. Severely malnourished patients have poor wound healing and higher complication rates, so some patients are going to need nutritional optimization before surgery. Prior abdominal surgeries have to be considered as they often create scar tissue that can complicate cytoreductive surgery. It doesn't automatically disqualify patients who are being cared for by experienced surgeons who know how to work through adhesions, but this does increase operative time and complexity. Distant metastasis, which is when the disease has spread outside the peritoneal cavity, generally disqualify patients. If mesothelioma has spread to the lungs, parts of the liver, the bones, or other distant sites, cytoreductive surgery won't help because removing peritoneal disease doesn't address the distant spread. That's one reason why chest imaging to rule out lung metastasis is part of any standard preoperative evaluation. How is surgical candidacy assessed? The initial evaluation includes a detailed history and physical examination, comprehensive imaging with a CT or MRI of the chest, abdomen, and pelvis, a PET scan to assess metabolic activity and detect distant disease, and blood tests assessing overall health and organ function. Radiologic PCI can be estimated from imaging, though this often underestimates the actual extent of the disease. Still, without surgical exploration, it's the best tool for the surgical team to assess resectability. Some centers perform diagnostic laparoscopy before committing to performing full cytoreductive surgery. This is a minimally invasive surgery, and it provides a look inside the abdomen with a camera, allowing direct visualization and more accurate PCI assessment. If the disease is more extensive than imaging suggested, or if the involvement of critical areas makes complete cytoreduction impossible, surgery can be aborted without subjecting the patient to a full laparotomy. If laparoscopy confirms that conditions are favorable for surgery, the patient will be scheduled to proceed to full cytoreductive surgery, either at a later date or immediately during the same operation. What if you're borderline, with PCI around 25 to 30 or other factors making candidacy uncertain? Experienced surgeons will assess all of the factors together. A 50-year-old with epithelioid disease, a PCI of 28, and excellent health, and with a favorable distribution might be a reasonable candidate, while a 75-year-old with biphasic disease, a PCI of 28, but also having heart disease and an unfavorable distribution, probably isn't. Some centers offer neoadjuvant chemotherapy, which is chemotherapy before surgery. For borderline cases, if the patient's tumors respond well to this and their PCI decreases, they might become a better surgical candidate. If the disease progresses despite chemotherapy, surgery is avoided. What if multiple surgeons give different assessments of your candidacy? This happens because surgical judgment involves a level of subjectivity. Aggressive surgeons might accept higher risk cases, while more conservative surgeons only operate on candidates they consider ideal. If you've been told that you're not a candidate at one center, getting an evaluation at another high-volume center is a reasonable thing to do. If multiple experienced peritoneal surgeons at different centers all say you're not a candidate, you should trust their collective judgment rather than continuing to seek someone willing to operate. So, what if that happens? What if you don't qualify for cytoreductive surgery? This does not mean you have no treatment options. Systemic chemotherapy with pemetrexed and cisplatin or carboplatin can control disease and extend survival. Immunotherapy combinations might be options. Clinical trials of novel agents are available. Palliative procedures can manage ascites and other symptoms. While outcomes without surgery aren't as good as with successful cytoreductive surgery, many patients live for months to over a year with good quality of life using non-surgical approaches. To review, cytoreductive surgery candidates have PCIs ranging between 20 to 30 or less, a tumor distribution that allows complete cytoreduction without involving critical structures, epithelioid cell type or biphasic if the tumor is predominantly epithelioid, a good performance status of ECOG 0 to 1, age and overall health that can tolerate massive surgery, no distant metastases, and evaluation by specialists at experienced high-volume centers. Assessment includes imaging, estimated PCI, and sometimes a diagnostic laparoscopy. Complete cytoreduction is essential for good outcomes, which generally deliver a 50 to 75% 5-year survival versus the poor outcomes that are common with incomplete resections. And finally, if multiple surgeons deem you non-surgical, focus on systemic chemotherapy and other options. You can visit mesothelioma.net for more information about cytoreductive surgery candidacy and peritoneal mesothelioma treatments, or call 1-800-692-8608 or use the live chat feature on the website to work with one of our patient advocates right away. As for me, remember to post questions below, and I'll see you next time.